This podcast is not CME eligible. If people do want to learn more about CME eligible podcasts, Alex, what do they do?
They can go to GeriPal.org/CME.
And on to the show. Welcome to the GeriPal podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, we have a returning guest with us today.
We are delighted to welcome back Bob Wachter, who's chair of medicine at UCSF. He's a hospitalist, in fact, coined the term hospitalist. He's an author. His prior book was called The Digital Doctor, and his current book that we're going to discuss today is called A Giant Leap. It's due out February 3rd. Early reviews have been fantastic. We last had Bob on in April 2024, and in fact, Bob incorporated that episode into the second chapter of his book.
Page 26, I think, something around there.
So even more reason for you, dear listeners, to check it out. Bob, welcome back to the GeriPal podcast.
It's a great pleasure. I thought if I could do anything to push you up to number one on the podcast charts, that is my effort to do that.
I had to share with my wife. I showed him the page that said GeriPal, mainly because the way you wrote about it, it said GeriPal, a popular podcast. And they love the fact that it said a popular podcast.
Well, it is. It is.
We're popular with a very small segment of healthcare providers who care for older adults and people with serious illness.
Well, Bob, thanks for coming on. Before we dive into AI, we'll talk about your book, some components of it, and mainly a lot of questions me and Alex have about it. We always start off with a song request. Now, this is interesting. Did you have a song request, Bob?
I forgot what I asked for. I probably asked for Springsteen, but what did you end up with, Alex?
Well, I think you actually asked if maybe AI could write the song. Is that right, Alex?
That makes sense.
How did that go for you, Alex?
That did not go well. The problem is that if I ask AI to come up with a song, it will come up with a song, but I don't know how to play it. Like, there's no tune there, right? There probably is some AI that could compose the song with a tune, but I don't have that AI. And then I said, okay, let's try to compose a song about AI to the tune Tomorrow, which Bob sang and played piano for on our last podcast. And it said, I can't exactly do that because the melody and the lyrics and the structure of the song are copyrighted. So it came up with a song that was similar, but too different to actually play the lyrics to. So we're running up against these boundaries here.
So then I jumped in.
What did you do, Eric?
I jumped in and I just asked AI. There's all this talk about prompt engineering. I said, after reading Bob's book, which I learned it's kind of a dying art because AI is getting so good. All I asked AI is, Bob Wachter's coming on the GeriPal podcast. What song request should he suggest? Like, nothing else. I think I said he's coming on to talk about his book. I didn't say what the title of his book was or anything like that. And it came up with what song, Alex?
Handle with Care by the Traveling Wilburys.
Yeah, and it actually came with an answer why it chose the song, which I actually like too.
It's pretty damn smart.
Yeah. All
right, Alex.
Say the answer, or should I jump in?
Just jump in, because I don't have
the Little Traveling Wilburys here. Been beat up and battered around, been set up and I've been shot down. You're the best thing that I've ever found. Handle me with care. I'm so tired of being lonely. I still have some love to give. Won't you show me that you really care? Everybody's got somebody to lean on. Put your body next to mine and dream on.
So I just looked it up. AI said he could opt for Handle with Care by the Traveling Wilburys, symbolizing the care and caution needed when integrating AI into healthcare systems.
Wow.
Boom.
Well, considering the fact that the last time we did this, I sang and played, this has already been a greatly improved episode.
Right. Your rendition is terrific.
All right, Bob. I got to ask the first question. Alex and I have a ton of them, but my first one, why this book and why now?
Well, why now is easy. I mean, the AI is transforming everything that we do. It's the hottest issue in the universe. It's propping up the economy. And I think why now? Because actually it's a perfect time for it. We're now 3 years into the AI revolution, which I really think began on November 30th, 2022 with the public release of ChatGPT. And 3 years is a good time. It's time enough to see what's real and what's hype and what's BS. It's time enough to see sort of the players emerge and who the leading companies are and how the money is flowing and how healthcare organizations and doctors and nurses and others and patients are reacting to using these tools. So I think the questions now and the answers to me are ripe enough that I think there's some clarity that I would not have had 2 years ago. And I'm not sure 2 years from now, probably things would be a little bit clearer than they are now, but not that much clearer. So it feels like a really good time. And this is the biggest experiment in the history of medicine. You think we do experiments for a living, but we are bringing in this technology, this kind of weird alien technology that in many ways is smarter than we are. And we have to figure out everything about it. So I think the timing is perfect.
It seems like in medicine, we're very slow to adopt everything, especially new technology, new drugs, like new whatever. But it seems like in the last year and a half, we are adopting AI very quickly. Is that your sense too?
I think we're doing it at about the right pace. I finished, when we spoke a year and a half ago, I think I wasn't sure how optimistic I was. I probably tilted a little bit toward optimism, but I'm actually quite optimistic about it now, in part because there are a number of forces that are in tension, but I think are playing out in a way that's net positive. The tension is, as you say, Eric, we tend to be pretty slow. We tend to be pretty conservative. There are regulatory guardrails like HIPAA. There's the malpractice system. There's a lot of culture and a lot of history, a lot of legacy stuff. Like, one of the things I've noted is if you take the 10 leading companies in the United States 100 years ago, they're pretty much all out of business now. If you take the list of the 10 leading healthcare systems, they're still the same systems. So we don't change very fast. On the other hand, the need for AI and the pressures to do something different than what we do, to deliver access and scale the expertise of specialists and make things better and cheaper, the pressures to try to do that are immense in healthcare. And I think those two forces are balancing each other out, that it's sort of the professional guardrails that we have that would normally have us go very slowly, I think are being balanced with the money that's in this, the remarkable capabilities that it has. And I think it's leading to something that feels about the right pace. Like, we shouldn't start with trying to say we don't need geriatricians anymore because I got Gemini. That would be stupid. On the other hand, we shouldn't say, let's not bring scribes in or chart summarization or help me draft a prior auth. Let's wait 10 years when the needs are so obvious and so immense. And I think we're starting with tools that are relatively low risk and relatively high yield. And I think that's kind of the right way to get started.
And can I ask, if you had to think about 5 tools that Bob Wachter uses in his professional life as a doctor, as a healthcare leader, can you give me examples of 5 AI tools?
Yeah. I don't know if I have 5, but I'll tell you some of the ones that I do use. So when I'm on the wards, which I was 2 weeks ago, I used Open Evidence, and I have no relationship with the company, but I used Open Evidence constantly. And I have a editorial coming out in the New York Times that I think will have just been out when we air this, where I basically started like that one of the things that's fun for me when I'm on the wards, because I'm a generalist, is sort of trying to hunt down my favorite specialist and get a curbside consult. I got this patient with a weird liver thing or a weird kidney thing or a weird pulmonary thing, and I'm hoping I kind of run into somebody in the library. Now I get probably 5 times as many curbside consults as I used to, but I get them from Open Evidence. I will use that in the way I used to use a human curbside consult. Yeah. Sometimes if I have a more general question, I toggle between using GPT and Gemini. Gemini's new Gemini 3 is extraordinarily good. They're both equally good. Those have replaced Google for me.
So is up to date out of your
gone, completely gone.
completely gone.
Yeah,
Wow.
if I want to read a chapter about a topic and go deeply in depth, sort of, then it's fine. But typically when I'm taking care of patients, I'm not asking, what's the right dose of Eliquis.
Yeah.
I'm asking, I've got an 80-year-old, man with Waldenstrom's macroglobulinemia who comes in with a fever, elevated LFTs, and a creatinine of 3.2. What do you think is going on? If you put that into up to date will choke on it. It has no idea how to answer a true clinical question. So, I will go to up to date to read a chapter about something. I'll try to, Open Evidence gives you the list of references. I'll go to a reference periodically. But it has become kind of the trusted curbside consultant. And then Gemini GPT for sort of general questions about everything in medicine or everything in the rest of my life. The rest of the tools I use Claude a lot for writing and editing. And I think I'm a pretty good writer. And my wife is an amazing writer. She's written 9 books and writes for the New York Times. And in the writing of my book, I would write a paragraph sometimes and Katie would edit it. And I'd say, this is pretty good, but it's not quite singing to me. And I put it into Claude and I say, Claude, can you make this better? I'd say 3 out of 4 times it did. So as the writer, editor, and I love Claude's personality.
Did Claude help with this book?
Yeah. I I wrote the book and every word there is mine. But there certainly were paragraphs where it's like, I'm looking for a metaphor or looking for a different way of phrasing this. Claude, can you help? And Claude almost always did. The other tool I used that was sort of interesting, I did about 110 interviews for the book. So each one ended up with a PDF that had 3,000 to 5,000 words. I loaded all of them into a Google tool called Notebook LM. And that creates essentially a database of all of those 110 PDFs. I then could say to that database, show me everybody who said anything about regulation or about HIPAA or about nurse practitioners, and can you summarize what they said for me? So in some ways, it's like the database, like OpenAI or GPT or Gemini, are trolling through the entire internet. It's now trolling through the database that's my 110 interviews. And I found that very useful in the writing of the book.
Do you have to worry about hallucinations with that, or do you feel like right now they've pretty much figured out hallucinations?
There still are hallucinations, but they're far less common than they were when we spoke a year and a half ago, and much, much less common than if you used GPT-3 when it first came out. I think that's important because if your impression of this AI thing, it's weird and like I can't ever use this in patient care because it could hallucinate, and if it hallucinates, it could kill somebody. You use Open Evidence, it just doesn't hallucinate hardly at all. And Notebook, I never found it hallucinated. If you look at the sort of benchmark rates of hallucination, they're not zero.
Yeah.
And this is in some ways one of the most fundamental questions in this whole field, which is for now, it's trustworthy enough to be really, really useful, but not perfect. And therefore, we get into all these discussions about the human in the loop. So I still think you need to look over its shoulder. I would not accept a diagnosis that was made by Gemini or GPT or Open Evidence without looking over its shoulder, because every now and then it'll come up with something brilliant. Every now and then it comes up with something that's wrong. But it doesn't hallucinate nearly as often as it did 2 years ago.
So I can imagine there's 3 buckets. There's jobs, right? Let's do a 3 to 5 year horizon from now. There's jobs that humans are just going to do as humans. And probably a lot of that is like the physical aspects of medicine and nursing. It doesn't seem like we've quite caught up there with like physical AI, like robots yet. There's jobs where the human has to be in the loop, or it's a combination of human and AI. And there's jobs that just AI will have taken over. Can you think of any in that latter group where just AI either now or in the next 3-5 years, you think like that's just not going to be a thing anymore?
Sure. I mean, let's start with non-physician healthcare jobs. At UCSF, up until about 3 years ago, we hired about 100 human scribes for our busiest ambulatory docs. I don't know if either of you had a scribe during any of your time. They were wonderful. They were usually pre-med students. We paid the company $30 an hour. They would sit there in the office. And, what was weird about scribes was every other industry computerizes and starts laying people off. Only we could figure out a way if we need an extra person to come in and feed the computer. But, they were a massive satisfier for the docs, and the patients liked it because the docs were making eye contact. And I remember at one point we talked about, maybe taking someone's scribe away, and the doc said, no, I love, this young person who I get to chat with. And so there were a lot of advantages. They're all gone.
Yeah.
They're gone because we now all use AI scribes. So it's the kind of job where you say the task here is to basically take a conversation between a doctor and a patient and turn it into a note that has to be formatted in a very particular way, and then maybe a way that also understands the billing system and the coding system. That was a job that we needed a human for $30 an hour, 3 years ago. And now every doctor at UCSF has access to an AI scribe that does a job that's probably as good as the human did and does it at a cost that's a fraction of what we used to pay. So I think that jobs like that, the 1,000 people that we have in our billing department, I think we need many fewer than that. The people whose job in the quality department is to go through charts and code them to send off as quality measures to US News or to other regulators, those jobs, I don't know that they go away or they're just markedly improved because the AI can do that as well as a human can do it, and do it 24/7 and do it at a far lower cost.
Medical interpreters?
Probably. I mean, I think that, now with your AirPods, you can interpret any language. So, when I'm on the wards, it's interesting because I think the most useful piece of technology in my hospital today is not Epic that we spent probably $1 billion for. It's the interpreters the video interpreters I can call up on my iPad. But does that need to be a human? Probably not. I think that probably gets replaced. In terms of the physician workforce, if you'd asked me 15 years ago, which comes first, that all the radiologists are out of work, or I get in the back seat of a driverless car and sometimes fall asleep and Waymo wakes me up when I get home, I would have said the radiologists are toast. In San Francisco today, I take a Waymo about once a week, and we can't hire radiologists fast enough. So I have a chapter in the book about why that is, and it's not just that the radiology lobby is really powerful. It turns out to be a harder task. But if anytime anybody says, well, that it can never replace a doctor because the stakes are really high and it's a really hard thing. Are you kidding me? Like, try making a left turn across Divisadero.
I think I remember from your book, the timeline for that seems to be one of those constantly on the chopping block with technology, has been very resilient, but with AI, maybe like a 10-year timeline?
Yeah, I think 10 years is not that there are no radiologists, but the radiologist work is massively facilitated by AI doing the first read and knowing when it's 100% confident that the read is right. Radiologists, you don't need to look at this. And maybe 10% of the films that AI says, I'm not sure, or this is a more complex film than usual. Radiologists look over my shoulder to see what you think. So I think that does happen for radiology and pathology. So the hierarchy here is the jobs. And, does that mean there are no radiologists? There's still interventional radiologists. There's still new techniques that get invented where there isn't a database yet that can be fed into the AI. But I think the jobs that are at highest risk, obviously, are radiology and pathology. I'd say jobs like yours and like mine, where you're mostly diagnosing and treating people, are at medium risk and will mostly be facilitated with AI rather than replaced. And then, surgeons, colonoscopists, I don't think get replaced anytime soon, but absolutely enhanced. So, right now, I mean, the Da Vinci robots are taking in the data on 10 trillion surgeries a year. Believe me, they are analyzing every bit of it, trying to figure out how do we facilitate the work of a surgeon. And then they will all say, that's what we're trying to do. We're trying to be a co-pilot. We're here to help. Your BS detector should go off because their economic value would be greater if they could actually replace the doctor. I don't think that happens anytime soon. But in colonoscopy, for example, do you need a gastroenterologist making $500,000 a year to do your colonoscopy? Or could AI enhance the ability of a lesser trained and lesser paid person to do this thing just as well? I'm guessing it could.
Go ahead, Alex. Wait, can I ask one more question?
Yeah, go ahead.
Because this idea of the human in the loop, because there's the human in the loop, from a technology standpoint, like, can you get rid of the human? It seems an easier lift than humans also add trust. And for doctors, they also add, you have someone to sue. Like there is this, oversight, which you write about this in the book, like a dystopian future where all we do is like, we are the shield for liability, responsibility. But where do you think the physician or the nurse or anything falls into that human in the loop from a trust to responsibility or liability perspective?
Well, I think there are lots of different issues embedded in that. Like there's the trust issue, which is that, one of the things I write in the book is that people generally will trust other people more than they will trust pieces of software and companies. But this is really weird because in essence, we trust a who more than a what. But we've never in the history of the world had a what that seems like a who, that emulates a who as well as anything. And, I trust Amazon. I trust Apple. I have put a lot of trust in technologies that empirically have demonstrated. Do I trust?
Do you really trust Amazon?
Well, to deliver my package safely and at the least cost and in the most convenience the next day? Absolutely, 100%. Do I trust them as a company? Do I trust their motives? No, but they're, it's a capitalist system and their motives have led them to deliver a product that does exactly what I want it to do and does it well and at a cost that seems reasonable compared to the alternative. So yes, I trust them to do this thing. I trust DoorDash to do its thing. I now trust Waymo to do this thing that is, I'm putting my life in the hands of a piece of rolling software. So we may be overrating the degree to which people need another human to do this thing that we call healthcare. And I'd be careful about sort of assuming that people will always want the human to do that, because they may want the human to do that, but then when you tell them it's going to cost them $300 an hour to get the human to do that, and you can have this other thing, and it's going to cost you $10 a month for your GPT subscription, I'm not sure. I'm not sure. And the analog I use in the book is to financial services and travel agents. There are still travel agents around. There are still financial people around to help you do some stuff.
Yeah.
And you use them if you've got particularly complex needs, and you use them if you can afford it. But we've been willing, and people care a lot about their money and are willing to use technology instead of a human if they feel like it delivers what they need at a lower cost.
Yeah, I was really fascinated about the accountant piece in your book because it does make a good analogy. Like, if you don't have a lot of complex financial needs, you don't really need an accountant. You can just use TurboTax, like you mentioned in the book, and save a lot of money. And if you have a lot of complex needs, you can pay a lot more money for a lot more services, and that money keeps on going up and up and up, kind of like concierge medicine right now.
Exactly right. So,
but it's a little bit perverse in medicine because a lot of the times the people who have the most complex needs in medicine is different than accountants are people who have no money.
Exactly. So we will have to figure out whether there are technologies that can help with those kinds of patients and make your jobs more doable. The healthcare system has all sorts of perversions built into it because of insurance and because of its cost. Let me just, though, before I forget, let me address a couple of the other things. I do think the malpractice system, the billing system, you need a human to put their name on a bill, not, you can't have a bill signed by Gemini.
For now.
Right now. Those will keep the human in the loop, longer than, in some ways, longer than you might expect. It's like, if we don't really know how to bill something, if there isn't a human doc signing off on it, if we don't understand and have figured out accountability, whether it's regulatory accountability or malpractice accountability, that will keep the human in the loop also longer than one might otherwise expect empirically. But the human in the loop is complicated. We will say to ourselves, all right, this is a safe system. The AI is right 97% of the time, and the human can sort of weigh in at the end and catch those 3% of errors. First of all, we suck at that. We're very bad at perpetual vigilance over a technology tool that we've learned to generally trust. Second, we will de-skill over time. We will actually get less good at that. And then you've probably seen these studies. There have been a couple of studies that have come out recently that looked at human and then human plus AI, and that was better. And then AI by itself, and that was better than the human plus AI. So the human added added mischief here. It made things worse than they were. And there are going to be circumstances where the AI is so good that when the human weighs in, they serve only to screw things up. So trying to calibrate all of that and figure out how to get it right, I don't know. But even the liability issue, I'm on the board of a company called the Doctors Company, which is a big medical malpractice insurer. And we spent a lot of time 2 days ago talking this through. Yes, right now, entities need a human to sue. But if you're UCSF, you may say, if I can get the AI to do the colonoscopy or do whatever the thing is, and okay, if it's ultimately safer than the human doing it or as safe at a far, far, far lower cost, okay, they'll sue, me for buying the technology tool and using it, or maybe they'll sue the technology company. But the system, that part's all math. The system is going to figure out like who to sue, and healthcare organizations and insurance companies, others will make rational decisions about, is this thing delivering the outcomes that we want? And is it doing it at a significantly lower cost than the ambient system? And I think in many cases it will. And then, malpractice will kind of sort itself out. Sure, there's not a doctor to sue, but then they'll sue the company.
I want to unpack a few of the things that you said. Maybe I'll go back to the beginning. In your epilogue, you write about being approached to write this book from your publisher and having some trepidation about that because, in part, the pace of change. And I wonder, we had dinner together with a visiting professor maybe, 6 months ago or something. And at that time, the book was essentially completed. And I wonder, is that trepidation you had substantiated? Are there things that you wish you could have included in the book or would add to the book or would say to readers now, at the time this is being published? Well, this will be the beginning of 2026 when this podcast comes out, but we're recording it at the end of 2025. Are there aspects of the way AI is integrated or the stories about AI in healthcare that have shifted even in that short period of time?
Not really. It's actually that part worked out really well. And yeah, when the publisher approached me, it was on February 20th or something, 2024. Mm-hmm. And I just read a bunch of the first sort of generation of AI books, which are mostly kind of, gee whiz, this is amazing and cool. And we should be, preparing for a world with this new kind of weird technology. And in part, what I was thinking was, all right, what if another moment like November 30th, 2022 happens where a new version of it scales at some level or, has a step function at some level, sort of so far beyond what we've seen that it makes everything I've said irrelevant. And I kind of made a bet that wouldn't happen. And that bet has paid off. If you look at the last, it took me a year and a half to write the book. So I got to watch the evolution over a year and a half. And there's probably 2 or 3 pages in a almost 300-page book of new content. I've got to say something about DeepSeek, the Chinese AI company. I've got to say something about Epic's getting sued by some of the startups. Some of the startups went out of business, and that says something about the ability of AI to sort of take over primary care. Stuff like the regulatory environment. I had to say something about the Trump administration and the change in the approach to AI regulation. But they're minor players. They were sort of incremental, it hallucinates less than it did, those sort of things. These were the general trajectory of what is happening, I think, is pretty well set. And I don't see anything that's happened in the last 3 years that is anything other than incremental and to some extent predictable once you understand the grand narrative. And so I worried about it and worried about getting scooped. I worried about, my God, some GPT's 32 is going to come out and make all of this irrelevant. No. And I think in healthcare, if you think of, people talk all the time, the biggest topic in AI world, not healthcare AI world, but AI generally, is AGI. Sort of, is it going to achieve artificial general intelligence, i.e. it's smarter than any human about everything?
Mhm.
People ask me about it, and I say, I don't care. I mean, I guess I do in terms of it building bioweapons or screwing up the planet in all sorts of other ways.
Yeah.
But in healthcare, it's already good enough that we, I think, understand the general contours of this thing's really smart, smarter than any doctor in certain domains, not as smart as doctors or nurses in other kinds of domains. Can't toilet a patient and do other physical tasks that we think are important, can't do surgery. And it's going to get better and better and better. But whether it achieves AGI or not, I think that's not going to be the issue at this point, is implementing it in this incredibly complex ecosystem with history and billing and regulations and
Right.
culture and zeitgeist and vibes and training programs and research and NIH and Trump and all that. Those are the questions, and I don't think they have changed materially over 2 years.
Okay, I'm going to keep moving here through some of the things I want to unpack.
Yeah.
I felt like in the book you were trying not to pick winners, and that there's, and I don't know if that was true or not, and I'm interested in whether you felt that, and whether there are probably people who will read this book and try to figure out which stocks should they pick, who's gonna win this race. But just a few moments ago, I felt like you kind of picked a winner on our podcast when you said you use open evidence, you don't use up to date, or use it very rarely, as you later explained.
Yeah.
And this is what I've heard as well. Like the residents are all using open evidence.
That's how I figured this. My daughter and son-in-law were residents of my program our residency. And a year and a half ago, I had never heard of open evidence. And a year and a half ago said, this is all we all use. And they are you look up canary in the coal mine in medicine in the dictionary, you see the picture of our residents.
I actually reached out to the CMO of Open Evidence, Travis Zach, and he reminded me he was one of my interns way back when.
Yeah, no, he was one of our residents and faculty members, and now is helping to run the company. But that was the moment, and the reason that moment felt super familiar was about 20 years ago. I wrote a textbook of hospital medicine and was really proud of it. And I gave copies to like the resident bookshelf, and I came in like 6 months later. It was pretty clear I was the first one to crack the spine of the book, which pissed me off to no end.
Right.
And what had happened was this new tool came out, and it was called Up to Date.
Yeah.
And it overnight supplanted. So, Up to Date has recognized that it better do AI the way Open Evidence has. They are doing that now.
Yeah.
I think they probably compete with them in an interesting way. But yeah, I mean. That won, at least in the short term, because it was so different and so useful.
It's also interesting because this all seems kind of a moot point, because you have all of these great startups, these open evidences, but then you talk about these larger behemoths, like the winners and the losers of the past, like Cerner versus Epic. Cerner, loser. You have a great chapter talking about Oracle, who now bought out Cerner. It's Oracle Health. I forget what Cerner is now called.
Oh, Cerner's now gone, but yes, they call it Oracle Health. Right.
Oracle Health. And it seems like, I mean, this is the history of America right there. You have these very large corporations. And I briefly looked at the Oracle Health website to see what it looks like. And it seems like their new system is everything. It's decision analysis. You got your scribes. You got everything. You got like open evidence, which isn't open evidence, but you have that built into their system. And it seems like is that the future, where you just have these large companies that do everything? And
I don't know whether it's the large companies do. I mean, getting at Alex's question, I didn't pick winners or losers, tried not to, because I have no idea. I mean, what I do is lay out sort of the mega trends, the politics, the money, and I try to give users sort of a sense of how this works. I think Epic is a huge winner here. I think that the fact that they own, if you have Epic embedded in your desktop today, Oracle would have to be 10,000 times better for a place like UCSF to pull out Epic and switch to a whole different underlying system. And yes, Oracle has redone the whole Cerner chassis to try to do something that's sort of AI native. That'll be interesting. It'll be interesting to see how well it works. But to me, how much better is that than Epic building a bunch of AI tools, which it's doing? Yeah. Or maybe at the end of the day, for something really complicated like what Open Evidence does, which is sort of the decision support, and where if you screw up, you can kill somebody. maybe Epic doesn't build it. Maybe Epic just embeds open evidence or a tool or the new version of UpToDate in it. That is clearly where this all goes. I mean, right now, when I was on the wards 2 weeks ago, I would pull out my phone and dictate into my phone, being careful about HIPAA, the key facts about a given patient. And it's stupid because all of those facts were actually in the EHR note. So in the future, I shouldn't have to say, this is a 92-year-old woman who comes in with a pulmonary embolism, but has a recent GI bleed. What should I do? I should be able to say, Epic or open evidence, what should I do with this patient? Because it's read the note, it did the scribing, and then it's read the past history. It knows everything. And not only should I not have to say, what do you think is going on? It should say to me periodically, doctor, it seems like you think this patient has pneumonia, but the patient still has a fever on day 6. Are you sure? Because I've looked at the last 10 million patients like your patient, and 97% of them, their fever was gone. What do you think is going on? So that, I can't see how that's not where this goes. And whether Epic has built the whole thing, or Epic is embedding in tools that are built by third parties, I think that's where the big business tension is.
Yeah, for our audience, they're really interested in, care of older adults, people with serious illness. How good are these tools for the patients I care for? I remember Eric did a service a few years ago where he went through Wikipedia and looked on there to see, what are treatments for advanced lung cancer, and palliative care was not mentioned. And so he did a lot of work to get them to change that. We recently used open evidence and put in, you have a 79-year-old woman who's been getting mammography. She has this, that, and the other condition, and this, that, and the other physical impairments. Should she continue to get screening mammography? And we were delighted to see that they mentioned e-prognosis in their answer, and that it depends on the lag time to benefit and her prognosis.
But you thought the answer overall was a good answer?
We thought it was a good answer.
Yeah.
Is that fair,
I think it's the thing that it struggles with, I think, is how do you piece it together for the individual patient in front of you along with their goals? I think that's really the next step. And that's kind of what's going on in the physician's brain, is not just what the evidence is, but then individualizing it to the person that's in front of you. That feels like we're getting on the cusp of it, but we're not quite there yet.
Got to be baked into it somehow. And how do you articulate and then operationalize those goals into the prompt, essentially? It's tricky. I think that's a new horizon. I would say, as this discussion sort of reminds me that we've been mostly talking about professionally facing tools, like the tools I might use when I'm taking care of patients. You're taking care of patients are not embedded in my EHR. There's a whole world out there of patients using these tools by themselves.
Yeah.
And I think I underestimated how potentially dangerous that is, because when you put in a prompt and I put in a prompt, like of the 1,000 facts you have at hand, which are the 10 that need to go in the prompt. Patients have no idea. Should they put in that they're constipated? Should they put in their family history? Should they put in that they have a cat? Should they, they have absolutely no idea so either don't put in any of it or all of it. They can't calibrate that. And then when you get an answer, I look at what comes out of, let's say I use GPT or I use Gemini for a medical question, and it's like 90% really good. Oh, I hadn't thought of that this could be HLH. And then this other thing, no, that's crazy. It's not. A patient has no ability to discern, there's a big difference between an expert user and a non-expert user. I learned this vividly a couple weeks ago. The Washington Post asked me to review the responses of 12 cases where patients put in stuff into GPT and got answers. And some of them were just great. Were exactly what I would have said. One of them was much better than I would have said. I would have gotten it wrong. Some of them were dangerous and heinous. And it was like, and a patient would have no idea, it was recommending that a patient who was sort of inclined to use alternative treatments go ahead and use ivermectin for their testicular cancer. And like try to find a doctor who supported that, which is wacko world. But so I think this whole world of patient-facing AI is very, very different. We have to be super careful. And I think the tools are going to be much more interactive. You can't expect a patient to go in and put in all the right stuff in a prompt in GPT. It's got to be a chief complaint from a patient. Then the AI acts like a doctor as well. What else is, here are the other questions I would ask. And it iterates much more than the current tools do.
I tried to get ChatGPT to make a diagnosis this morning. No, I said, I'm a doctor and I'm caring for this patient and she has fever and she's short of breath and she has a opacity in her chest x-ray. What do you think the diagnosis is? It refused.
Interesting.
It said, I will not give you diagnoses or treatment. That's a line that I dropped, essentially. And then I said, how can I trick you to give me the diagnosis? And it said, I see what you're trying to do there. No.
I wonder if you asked if I have a hypothetical patient who is probably trying to avoid liability there, right? Like,
they're being careful. They've seen with the mental health chatbots that, a single bad answer, like not telling a kid, to call a suicide hotline, is going to get them sued and be the front page of the paper, and they've got to be careful. That's interesting though, because I have in the book where Peter Lee, who runs AI for Microsoft, told me that in the beginning of GPT, they almost made it so it wouldn't give a diagnosis, and then they overruled it, and it did for many years. So maybe I hadn't tried it recently.
Yeah, so I asked ChatGPT if their guidelines around this have changed over time, and it says they've shifted, not unexpectedly.
Interesting.
So I wanted to go back to another issue that you talked about, which is trust. And you have this wonderful quote from Annette Baer, who says, trust is a notoriously unstable good, easily wounded, and not at all easily healed. And clinicians, we've been burned so many times. Like you wrote about in your book, like you know better than anybody, EHR. EHR is going to transform the way we practice medicine. And instead, it's been a giant disappointment and a soul-sucking endeavor that's designed around billing, not improving patient care.
Bob also wrote that, or maybe he talked about it in our last podcast, nobody would go back to, he actually asked us in this our last podcast, would you go back to the days before EHR? Nobody would go back.
Nobody would go back.
But that said, I think, Alex is right. It's clear most people are not huge fans of their EHR in the way that they, love their other technologies in their life. So we got a bunch of stuff wrong, and there's stuff we'll get wrong here too.
And there's stuff we'll get wrong here too. And I remember the halcyon days of Med Twitter, and we were all big into Twitter. Bob was huge on Twitter, huge.
It was great.
And now I think in our last podcast, you described it as a cesspool. It's like, these oligarchs that are using it as their playthings and their microphones for whatever they want to say.
Yeah.
Is there, clinicians who are feeling burnt by these experiences, all right, and maybe us included, you come down with this optimism. You call it a giant leap. But is there a world in which 5 years from now, you feel like I should have titled it a giant letdown?
I don't think so. But here's I think the difference, Alex. From if you think about how Netflix transformed the way you get entertainment, or Amazon transformed the way you buy things. It's not like the world of bookstores or the world of network television or movies was so broken that everybody said this whole thing is failing. We need a technology. It's just that these technologies came out and consumers voted with their feet that these are better or more convenient or less expensive or whatever it is, that we're going to use this thing. It makes my life better. Healthcare is not like that. Healthcare is so fundamentally broken. The existing status quo is awful. And part of my optimism is we can't get much worse. I mean, that's not a particularly uplifting thing to say, but part of my optimism is we start out in a world where you have wonderful doctors and nurses and social workers. You have patients in vast need. You have new medicines for everything and amazing surgeries and procedures that can help. And none of it works. None of it is convenient, satisfying for either patient or doctor. It's wildly expensive. It's wasteful. It's soul-sucking, sapping in all sorts of ways. So we start with a situation where the pull is so much greater than in other industries. And that's why I'm optimistic. I'm also optimistic because I think we're being smarter about it. Here at UCSF Health, we have a way of governing what tools we bring in that's much more robust than what we had 10 years ago. The technology vendors now know they better have docs and nurses sort of working side by side with the engineers. And, somebody who just created this wonderful technology to do financial tech or travel, they don't know anything about healthcare. We better have healthcare people who are there helping to build these tools. And I think we're also going to be smarter. You start with stuff like scribes and chart summarization. And can you help me write my discharge summary? And can you help me write my prior auth? And that is how you build trust. Where the rubber's going to meet the road is as the tools get more agentic and do stuff themselves, and as they get more prescriptive and begin saying, here is the right treatment for this patient in this circumstance, there's going to be some pushback because, should it prescribe an Alzheimer's medication that may slow the progression down by 3 months but costs $50,000 and has a 2% chance of causing a brain bleed? Is that a good thing? Now, I would trust what you would tell me about that, but what a computer would tell me about that decision is so value-laden. And as Eric said, also, one of the most important value is the patient's values that it has no way of embedding. So it's a lot.
You also talk about in your book corporate bias and other biases too. That it's fairly easy to adjust an AI algorithm to favor a particular interest potentially.
Right. If it's a health system bringing in an AI and it's going to get paid more for treatment A than B, or we're being paid in population health, so let's use a less expensive thing. That will probably be what the tool recommends. So there's a lot of mischief. And then open evidence right now, it's free to doctors. Why? Because there are ads. When a tool like open evidence gets embedded in Epic, are there still going to be ads? That sounds creepy, but maybe.
Or sponsored results.
Sponsored results, exactly. Maybe, here's the recommendation generally, but here's a sponsored result for, this really wonderful, very expensive new med. So there's a lot going on under the hood there that could lead to some disappointment. But over the time horizon, at least that I can see, I think the needs of the healthcare system are so immense and unmeetable with our current strategy, which is always just to hire more humans. We can't afford them. We can't find them. And I think the technology is good enough that I came out of it pretty jazzed. I think it's going to be good.
Okay, lightning round. Lightning round, Alex. We can,
lightning round.
Yeah,
go for it.
Lightning round. You have a beautiful ending to this book that kind of gets back to the reason that, well, it's not a whodunit. So is there any chance you would read some of the end of your book? Or do you feel like that's giving it away? I don't know if you have it in front of you.
I sometimes when I speak, I'll read it. I don't have it in front of me.
Because what this gets to is
Alex missed the concept of lightning.
Yeah. No. I mean, Alex, you want me to read 200 pages? I'm happy to do that. But I'm actually taping the audiobook next week, so we can just have that be one big stream.
Right. Well, maybe we'll summarize it then.
Summarize it, Alex.
And the idea that there will always be a doctor. They will need a doctor. And maybe not always, but that our patients will need a doctor. And the reasons that, at least in the near term, in the interactions that we have, there needs to be a doctor. And I wonder, in a lightning round way, as my last question, why you say that.
Yeah, I mean, when I was in the Wards about a year ago, I, for about 10 days, did like a fantasy world where I just tried to use AI for everything and really kind of guessed like what it would be like in 5 years. And I came to believe that it would be really, really good and probably save me 10, 15% of my time. But so much of what I was doing was coordinating and dealing with patient preferences and family meetings and dealing with complex shifting teams. And it just seemed to me, and empathy and trust. And it seemed to me that these tools are not going to replace that in the foreseeable future. And they shouldn't.
Mm-hmm.
Yeah.
50 years from now, who the hell knows? But I won't be around.
It's interesting because Bob Wachter, amazing doctor, reminds me of Gurpreet Dhaliwal's New England Journal, where he faced AI in a clinical case description. We'll have a link to that in October. And Gurpreet did amazing. Like he diagnosed a toothpick that caused an ulceration, which caused sepsis, better than AI. But AI did really good on that too, I would say. That's how I would sum it up. But there's a lot of bad doctors out there too. Maybe not great, not empathetic.
Well, I'd say one of the lines I love and use it a couple times in the book is Joe Biden's line, "Don't compare me to the almighty, compare me to the alternative." And even when we talk about, chatbots and that they go off the rails and do something terrible, I think in that same conversation, as we talk about how we need to regulate them and make them better, you got to say, like, try to find a psychologist, a psychiatrist in San Francisco. And if you do, it's $300 or $400 an hour. So, and try to find a geriatrician.
The one thing that a doctor has is it has like a fiduciary duty. It has an oath. Like the patient is supposed to be primary. Like that is your person. You have this duty to the patient. AI bots don't have that. Should it
I think that's why I'm more trusting of an AI that's brought into an existing healthcare organization and working under the supervision of a credentialed professional for now.
Yeah.
And where this really does get dicey is when you're talking about direct-to-patient stuff. I think they probably are going to need to either have some version of the Hippocratic Oath or a regulatory environment that gives them accountability for doing things right.
Bob, I want to thank you for being on this podcast. I encourage all of our readers to get his book, A Giant Leap. We'll have a link to it in our show notes. But before we leave, a little bit more of, what was the song's title again?
Handle with care. Handle with care is a little bit more.
It was really fun, guys. See ya.
I'm so tired of being lonely. I still have some love to give. Won't you show me that you really care? Everybody's got somebody to lean on. Put your body next to mine and dream on.
Again, I encourage all of our readers to look at his book. You can learn why AI may be a sycophant and other great things from Bob's book. Bob, thank you for being on this podcast.
Thanks. It was really fun.
And thank you to all of our listeners for your continued support. We'd also like to do a brief shout out to those listeners who've donated more than $250, including
Kate Mesrich, Jen Hopping, S. Ashad Abid, Michael Bordowski, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Bragman, Elizabeth Chung, Paul Amatelli, Brian Cassell, Victoria Braun, Susan and John McFadden, Christopher Heck, Emise Simoji, Matt Schuster, Carrie Hagan, Lloyd Woolstadt, Carrie Levy, Mamie Fetzer, Ron Sabar, Stephanie Gabatuller, Patrick Lally, Richard Lewis, Margaret Leung, Cindy Harris in honor of Emily Guillot, April Sear, Anna Nayak, Xinyi Wang, Sudha Chandrasekhar, Michelle Reisner, Asher Edwards, Susan Nelson, Rebecca Goldstein, Rochelle Bernacki, Carol Dietrich, Mark Andrews Wren, Elizabeth Cobbs, Amy Rack, and Meg Walhagen.
Your support keeps the microphones running, so thank you very much.